You can have a tech just hold it down too. I try to use these pads when I secure people down. It's just a little bit more comfortable. You may or may not have those in your gym. You may choose to use them or not use them. If I don't have this, I'd probably get a tighter. But again, so patient comfort versus what I'm trying to get. If I feel like what I'm getting is acceptable using this, then I might use this just because it's more comfortable for the patient. If I really feel like it's not getting what I need, then I need to make that change because I'm not doing the patient any service by that. You're smiling at me, Cameron.
I know. He's getting some good shots of you. That's
He's getting good shots of me.
It's like a...
Okay. The subtalar joint. What kind of mobilizations can be done with the subtalar joint? I put them up on the slide.
Lateral, medial lateral.
We can do medial lateral glides. We can also do... We can do traction or a distal glide, inferior glide. Okay, those are the mobilizations. Subtalar joint. What motions are performed at the subtalar joint?
Inversion, eversion.
Inversion, eversion, but mostly supination, pronation. The combination of the three: dorsiflexion, plantar flexion, inversion, eversion, and then also internal, external rotation happen because of the oblique axis of the subtalar joint. Okay. For medial and lateral glides, when I'm with a person and I'm just doing oscillations or I'm interested in medial lateral glides, there are a couple of ways you can do it. This is the way I just always end up doing it because when I'm working with a person, I'm generally in this position with them. And if I'm thinking of the subtalar joint, if I'm going to do a lateral glide or a fibular glide of the calcaneus on the talus, I can stabilize the fibula and the talus and then just do my lateral glide this way of the calcaneus. So my thenar eminence is on the calcaneus. This hand is stabilizing the lateral fibula, which the talus is right underneath, as well as the top part of my hand on the talus as well. And then I can do a lateral glide that way. If I want to do medial glides, I simply just switch my hands around, and I can do medial glides this way, okay? You can do them in side line as well, if you can lay on your side for me this way. Okay. I can have him bend his knees some. So from a stabilization standpoint, I could use a wedge. Probably better here, though, would be one of the weights, the ankle weights. Place it under the fibula. Can I ask you to bring... Yeah, like that. So with his leg behind him, I felt like he was too forward this way. I brought his leg behind him and shifted his body weight backwards, so now he's more straight up and down. And so the ankle weight is stabilizing the talus and the fibula, and then I can just do a lateral glide that way on the subtalar joint. Okay. Conversely, I can have him flip over the other way. Same position here. Just bring that leg out from underneath you there and get more, so he's more on his side. Bend your knees. There you go. Much better. And so from this position here, there is a space between his calcaneus and the table, so that's where my mobilization movement is going to be, and I can do a medial glide this way as well. So those are the two ways to do medial and lateral glide. Can you lay on your stomach for me? To do distraction or to do traction. And then the distal glide. Scoot back some for me. Scoot, no, that way. A little bit more. There you go. Okay. A little bit more. There you go. We don't even need the wedge for this. You can just be here. The joint plane for the subtalar joint is in this direction when they're on their stomach. Okay? So to do a distraction or a traction, which direction of movement does mine have to be? It has to be perpendicular to it 90 degrees. That means my force of movement needs to be almost towards the ceiling in that direction. So the way we can do that is that the table itself is going to stabilize the talus and that articulation there. But now I can get on the calcaneus, and the goal of the movement here is you do a horseshoe grip around the subtalar joint, and my motion, the mobilization I'm trying to do is up and in that direction, okay? I can make this a little bit better. Does someone have a pillow? Can I grab a pillow real quick? Thanks. That's fine. Flexing his knee. Flexing his knee, so I'm still getting the stabilization of the talus. With the foot in full plantar flexion, you get that, but you can also stabilize the talus there. That gives me a little bit more of an angle to go up towards the ceiling, and I can do the distraction that way for the calcaneus on the talus. To do the distal glide, the inferior glide, the joint is in this direction, so that's the angle of my movement. So instead of being up and towards the ceiling, I'm going to go down along basically the angle of the foot, so I bring my hand up, I stabilize the talus, and then I can just do the distal glide that way. So now I'm shifting the calcaneus this way, where before I was trying to separate it away and lift it this way. Okay?
What are the last two for? I'm sorry. So what is the distraction in that?
The distraction is up and forth this way,
right,
but the inferior glide is this way.
and what osteokinematic movement am I?
It's the subtalar joint, so it's all for pronation, supination. If you're just seeing hypomobility, you stretch it out. If you're limited in supination and you're finding that, I think the reason why is that subtalar joint's hypomobile. When I test that motion, it's not moving well, then you're going to mobilize it. Okay?
That second one you're doing, how is that not anterior if it's in an anterior direction?
I think they're considering it. It's just I guess they're considering it the plane to be a little bit more this way than straight down. I just know that's what they call it.
So would you do
I'm not
superior?
going to make up.
Would you do a superior glide?
Would you do a superior glide? Honestly, I've never learned that. I haven't seen it written in any tests, so I don't do a superior glide. These are the ones that are just out there that are accepted manual therapy techniques. So and those are the ones I know. So those are the ones I do. So the answer to your question is no, I don't do that. The lower leg, the distal tib fib joint. Can you lay on your back for me? That one's pretty easy enough because you're just going to stabilize one and mobilize the other in an anterior-posterior direction. If I'm interested in mobilizing the tibia posteriorly, the fibula anteriorly, I'll stabilize the fibula, and I can go ahead and do a posterior glide, a relative anterior glide of the fibula. Okay? So the base of my hand, for everyone on this side, is stabilizing the fibula head, and then my mobilization force is through the tibia. Okay, I would reverse that if I'm interested in doing a posterior glide of the fibula. My stabilization hand will be behind the medial malleolus. My mobilization hand is now on the anterior fibula, and I'll do an anterior to posterior there. So now I'm doing a posterior glide of the fibula, or an anterior glide of the talus, or the tibia, excuse me. So just on this side, I'm stabilizing the medial malleolus on this side. Now my hand's on top of the fibula, and I can do a posterior glide of the distal tib fib joint there. Okay? Again, with this one, there's no rule as far as which one's more dorsiflexion or plantar flexion, but if there is tightness between the two, and they're not moving or shifting correctly, especially anterior-posteriorly, there's no way for us to test it or know, but the assumption is, and there really is an assumption that if they're not gliding very well anterior and posteriorly, they may not be separating so well either. If there's hypomobility in one direction, there's a possibility there's hypomobility in the other direction. So you do some of these, and then you retest your ankle dorsiflexion and see if you're getting any more or not. And if you are getting more, then that would probably be the reason why, because they're not shifting anteriorly and posteriorly during dorsiflexion, but they're trying to separate and come back together, and so maybe you're improving that. You'll never know 100% for sure, but that's, if you're getting stuck and you're doing all these posterior talar glides and it's just not getting better, sometimes looking at the articulations in the midfoot, because we talked about dorsal glides being for dorsiflexion, but also looking at the distal tib fib joint and seeing if we can loosen that up, maybe we start to see bigger ranges of motion, better gains, as opposed to just getting stuck on posterior glide dorsiflexion, posterior glide dorsiflexion. And if it's not coming, then maybe you need to look somewhere else.
Question.
Mm-hmm.
to fit?
I generally do it both ways, and I see which one's tighter. No, I wouldn't say I favor one over the other. No. Okay. Soft tissue techniques for the gastrocs. The way I do that, and let me have you flip around the other way. I need your head this way. Yeah.
On my stomach?
On your stomach. Scoot backwards some so your ankles are just off the edge of the table. And the reason why I want them in this position is because this table is going to allow me, and I didn't have them do this for the mobilizations, but sometimes you do. Sometimes you can get a better sub-tailor if you have the ability to put a person in this position. You know, going anteriorly, you can do some of these in this position too, that you can set up the table so the person's relaxed some. So if I'm doing a muscle-guarded gastroc soleus, I probably want them mostly in a mid-range position. If I had the bed completely straight and their foot hanging over the edge, that would be an end-range stretched position. So by flexing the knee some, I put the gastroc on a little bit of relaxation. The first phase of the soft tissue technique, if it's the medial gastrocs I'm concerned about and the ones I'm going after the most, the first part is just those slow strokes along with the muscle fibers. I might spend a few minutes on the medial gastrocs. If I have to do both, then I'll spend a few moments on the lateral gastrocs. Okay? I might do that for a few minutes. It's going to be different from person to person. But what was the next phase that we showed you guys when it came to the
Passive pump.
the passive pumping, right? So what is that passive pumping phase? What do we have to accomplish?
Blood flow.
Mm-hmm.
We want the muscle to relax, but what do I need? What is that passive pumping phase?
Your passive is laying.
Into a shortened range or a lengthened range?
Shortened.
Into a lengthened range. So as that tension is building up, so what I'm going to do is I'm going to apply a downward pressure on the foot, okay, on the gastroc, and then as I'm passively extending his ankle, dorsiflexing his ankle and stretching the gastroc, and that bulges, and I feel that pressure underneath my hand, I come off the pressure with my hand. I don't remove my hand from them. So the way that's going to work a few times, I'm going to put him in the shortened range, I'm going to apply my pressure, and as I'm lengthening him, I will come off that pressure. Then I will passively bring him back into the shortened range, reapply pressure, re-dorsiflex. And I will go through this sequence 20 times, 15 times, a minute, 2 minutes, whatever works best for my patient, okay? To show you guys on this side, if you didn't see it so well, I'm placing him into the shortened range, I'm applying pressure, and then as I'm dorsiflexing him and his muscle is stretching, I'm going to feel that pressure of his muscle stretching out underneath my hand, and so I let off that pressure at the same time. I will passively bring him up into plantar flexion, re-dorsiflexing. Bring him back into plantar flexion, okay? And just work on that. The last phase of the soft tissue techniques is what? Active pumping. So this is where I need him to make a gastroc muscle. So what I'm going to do is I'm going to put him well, not even so much put him into length range, but a little bit. I'm going to put some pressure on your leg, and what I need you to do is point your toe at the same time. So go ahead, do that, point your foot, and as that muscle's bulging up, I come off. Okay, now let it go. I bring him back to the start position as best I can. Apply pressure, now once again, so he's actively, go ahead again. So he's actively doing his gastrocs. I'm coming off the pressure of my hand as he's doing that again and again. I'm going to try to be the one to let him back down so he's not eccentrically lowering his gastroc. Just for this side, so this side can see a little bit better. He's going to be in a somewhat lengthened range. I'm going to apply pressure if it's the lateral gastroc, so I'll apply that pressure on the lateral gastroc. Go ahead, point your toe, and then I come off that pressure. He relaxes. I bring him back down, pressure, and then he contracts. I bring him back down, pressure, he contracts. Okay? So that's just one, and like we said, from soft tissue techniques, this is just one of any number of acceptable methods, but this is one that you can start to practice right now, okay? The last thing we didn't go over, but you're going to do exercises for the gastrocs, okay? Think dosing, think how can I do a therapist-resisted exercise and exercise that doesn't require the therapist to be present. ankle weights, we have elastic bands, we have more back here. So go ahead and do that. And then not